case of the soldiers in battle that can sort of go on and rescue several of their buddies, even though like half of their foot was been blown off. These guys can continue on for hours and days, and then only later, while they're recovering in the hospital, do they start to complain and say that their foot. You have all the anecdotal evidence from sports injuries, etc., where people can continue to play through these sort of horrific kind of injuries. So these kind of anecdotal evidence and what just intuitively we know about pain, we don't really fit into this model. And so it was really in the 1960s when the theory or pain kind of got sort of turned on its head, and there was a bit of a revolutionary sort of change kind of came about. And it really came from these two gentlemen here. So this is a British neurophysiologist named Patrick Wall, and this is a Canadian psychologist actually from Montreal named Ron Melkat. And they actually were both sort of working kind of separately down in the United States at MIT, and just happened to sort of come across each other. I think Pat was looking for some equipment, or Ron was looking for some equipment in Pat's lab, basically. And they both realized that they had an interest in pain and started kind of chatting about different aspects of pain and how the theories could be sort of modified better to sort of mirror what we do. And so basically what they came up with was an answer to the specificity theory, or a challenge to the specificity theory, with this gate control theory of pain. And so this is really, I said, was quite revolutionary at the time, and it's really sort of taken over, and is now, I would say, Francois from the medical school, this is sort of the dominant theory that's now sort of put out in textbooks and in training. And this is really a simple sketch, and I think when you get the overhead from talking, you have to see the diagram in a little more detail. And actually, if you go online and do a little Google search for gate control theory, you can actually see the original sort of little paper sketch drawn in pencil by either Pat Wall or Ron Melkat, sort of outlining the original sort of conception. And in its original conception, they actually didn't even have a brain involved, which is also something fascinating. Anyways, if we look at the sort of theory and what it was trying to do, basically the idea here is that pain is not a static one-to-one stimulus response. Pain is modifiable, it's going to be modified. And so what they proposed, theoretically, is that within the spinal cord, at that first sort of point of entry where sensory information comes in, there's a gate that can either be open or closed to allow sort of information up into the higher centers of the brain to interpret or ignore a pain signal. And so we can see the kind of the setup here in the wiring. Basically, the theoretical framework is that we have two classes of cells. We have these transmission cells, these T cells here, which are the ones that are receiving input from the periphery. They're the relay cells, essentially. They're going to send stuff up to the periphery. And then, really, the important class of cells are these gate cells here, these Ts. And so, in a certain context, what you have is not just stimulus from the periphery is going to activate an A delta or a C5. And that input is going to come through here and basically act upon a transmission cell, send the signal up, and then we will perceive pain. And what it's doing now at the time, if you look here, we have a little minus sign. So basically that input is not only acting directly onto the transmission cell, but it's basically inhibiting that gate cell, shutting it down, and basically opening this gate input can come up. Now the gate, as I said, could be shut closed by other inputs, and typically, if you look at the way the system is kind of theoretically wired up, information in these low threshold, these fast conducting A beta fibers, basically the ones that are about discriminative touch and proprioception, they actually have the ability to sort of activate these gate cells and basically shut down sort of information coming from the other side. So basically, these can close the gate, if you will. And so this is a way in which we could sort of account for some of these sort of pains being either shut down or allowed through into different settings. And actually, in sort of a sort of real-world scenario, if any of you have ever had any physiotherapy, a very common sort of machine that you see often in physiotherapy clinics are known as TENS machines. So this is transcutaneous electrical nerve stimulation. And basically, what a TENS machine does is it works basically on the gate. TENS machines deliver activation, and they activate A, these large diameter A alpha fibers. So basically close the gate and relieve pain, at least transiently, in people who are having some difficulties with chronic pain. And in most of us actually probably don't even have to spend the $50 an hour physiotherapy to experience the gait control theory. Because this is exactly what we do day to day. Again, if we take the thumb getting hit by the hammer, when we rub our fingers and thumbs, that's exactly what we're doing. We're activating these low threshold A beta and K alpha to make it feel better and basically to dampen down the impulses. So that's a rough sketch basically of the gait control theory. And I think what this does now is it sort of sets us up for sort of where pain is now seen. Pain is not a static sort of sensory experience, but it's a very plastic and very dynamic sort of state. We have conditions now we've seen where pain can be sort of dampened down, we can shut the gate down. But there are also sort of scenarios too where we really want signals to sort of be amplified. And so if we have enough tissue damage with a certain injury, we don't want to keep walking on a broken leg. We need to actually recover and heal. So we need signals to basically amplify and tell the nervous system, you need to sort of stop and rest and recover. And so there's a lot of mechanisms involved here for that. And so some sort of classic sort of definitions of amplified pain states are terms known as, these are the more clinical terms of hyperalgesia. So now the organism of you and I are going to be more responsive to potentially tissue damaging or noxious stimuli. And then the other phenomena that sort of comes about is known as allodynia. So this is where we have amplified signals in the nervous system that basically tell us that even things that really are non-noxious and things that are like light touch or whatever, these sensations can become very painful. So these kind of sound sort of bad, and we probably wouldn't really want to have allodynia and hyperalgesia, but in a certain sense you can look at them as being adaptive. These are sort of natural and quite good because they can serve this protective function. As I said, you don't want to continue walking around on a broken leg for many weeks. You need time to recover. And so one of the classic sort of mechanisms that can lead to these amplifications of amplifying pain signals is known as sensitization. And so we'll look at some of the basic sort of neurobiological mechanisms of sensitization here. And the thing, again, too, to think about sensitization as well is that it can occur at every sort of level of the nervous system. So we've started out in the periphery and we've seen the sensory neurons in the posterior ganglion. It can happen out there. You can have changes within the spinal cord, and then ultimately we'll see it go all the way up into the brain. So if we start out in the periphery and keep sort of looking at these posterior ganglion cells, this is kind of a typical sort of scenario if we're going to take sort of tissue injury or some very serious damage occurring. Now, I don't really want this slide to sort of sit there and memorize this list of the stimulus and the receptors. This is really just kind of an illustrative slide to show you how difficult it is in a sense to sort of attack pain, because pain is not mediated by one single factor. When there's tissue injury, there's not sort of the pain factor that gets released to activate cells that lead to pain. In fact, what people often talk about are things known as inflammatory soup. So tissue injury leads to the production of many, many different factors, from nerve growth factor and prostaglandins are down here, and it's very common. We'll look at prostaglandins a little more later. But you can see there's many other sort of substances that all actually have the capability of acting upon the primary nociceptors, these arm detectors. And that's really the point here. Again, don't worry too much about knowing specific receptors for specific things. Really, the message here is that we have a soup that can all influence and change the way these cells are going to respond to stimuli. And the important thing about this inflammatory soup and these mediators and how they affect the primary sensory neurons is that they don't sort of directly excite cells themselves. These mediators typically act indirectly, right? So the way that they're going to change the way a cell is going to respond to subsequent stimulus is not by sort of just activating it and making it fire very quickly. They're a lot more gradual and a little slower, and they typically act by modifying second messengers within the cells, which then go on to modify sort of the more important ion channels which generate the tension. So if we took the example, for instance, of the prostaglandins, because this is probably the most common one, and we'll see this sort of later on down the line as well. But if prostaglandin gets produced following tissue injury, it's going to activate a very specific receptor, which is expressed on these nociceptors. That's typically going to activate a And pKa then is going to go, as I said, to modify these sort of important ion channels, which are the sort of generators of the active changes. So voltage-gated sodium channels are a very key sort of target here. And so by modifying the voltage-gated sodium channel, by adding a little phosphate group to it, what this has the capacity to do then is to sort of change how this cell, or how this channel responds to any subsequent stimulus. So it might sort of modify it in such a way that the channel now, when a stimulus comes, remains open for much longer. It might change it in such a way that now the cell will actually begin to open at a different sort of threshold of the stimulus. And it can happen in very different ways, but the net effect of that is that the output of this cell to a stimulus is going to change from where it sort of began. And I think these key graphs illustrate this kind of nice principle in that here. So A and B, up in the top traces, you have a nociceptor sitting in a dish, and it's going to be responding to a stimulus. So this is a noxious heat stimulus, 49 degrees. And this cell, this is a typical firing pattern. So it responds to this noxious stimulus. This cell, this is the pattern over here. So we take that nociceptor then and we expose it to the prostaglandin for 15, 20 minutes. And now, if you come back and you present the exact same stimulus with 49-degree heat, you can see a significant change in how the cell is responding. So in this case, the cell is now actually beginning to respond at a much lower sort of threshold. So now the cell will actually start firing at 45 degrees, 44 degrees. In this cell, the threshold never changed, but look at the difference in the output. So you're getting the same sort of stimulus, but now the spinal cord, this was actually attached to the spinal cord. The spinal cord would be interpreting a much greater sort of impulse, if you will, which then can translate up to a greater sort of sensation. Okay, so that's basically kind of the sort of standard mechanisms of peripheral sensitization. These things that I suggested kind of happen at every level. So if you look sort of shifting the spinal cord, you can see very similar sort of processes happening over here as well. So I'm not really sure why it's always about a thumbtack, but anyways, this is a sort of the easiest stimulus you can think of. This is the normal state of everybody in the room at this moment right now, for instance. If we step on the thumbtack, the impulses from the C5 is going to come into the spinal dorsal horn right here, and this is where they're going to make their first contact in the nervous system. And basically what you have is that these cells typically use excitatory amino acids, glutamate, aspartate. These are the sort of standard neurotransmitters. And in cases like this, the glutamate signaling is typically through these AMPA receptor channels. I think we've come across these a couple times now from Peter's talk and the epilepsy talk before. So this class of glutamate receptor, known as the AMPA channels, really are the mediators of this kind of acute day-to-day pain, if you will. They're very fast, they open very rapidly. And in this sort of scenario, glutamate gets released. The other class of glutamate receptor, which we've also come across, the NMDA receptor, these actually remain kind of inactive in this condition. You don't really have them involved. And that's mainly due to this, what's known as this magnesium block. So in the channel of an NMDA receptor, there sits this little magnesium ion. And basically it kind of keeps the channel from anything from passing through it. And because it's a positively charged ion and it's sitting there, what it needs some depolarization of the membrane to sort of come to a certain threshold to actually kick it out and allow this channel to become sort of active and open. So you can imagine where this is going now. It's going to move over into a sensitized state. So now we've maybe stepped on a jellyfish and we have a significant amount of inflammation here. And now we're going to step on the thumbtack. We're very unlucky today. But that inflammation and jellyfish thing has caused some sort of change on the periphery, and it's changed the way the primary nociceptors are. Now they're sending 10 times more impulses into the spinal cord. So now we have sort of 10 times more glutamate being released. Or we could have other sort of factors that are expressed in the cell, different neuropeptides. It doesn't really matter the specifics, but basically the idea here is that there's a lot more input coming into this spinal dorsal horn. And what that will do then is have the effect of activating those fast AMPA channels. And because it's being a little more sustained and there's a lot more of it, the membrane is depolarizing. And now the NMDA receptor is opening because the magnesium ion can be picked up. particularly the NMDA receptors are important because by opening, they allow a lot of calcium to rush into the cells. And then the calcium can then set off the cascades of second messenger signaling, which then, of course, has the effect of going and feeding back and modifying the way the AMPA receptor channels are going to function down the line. So we can sort of see these kind of feedback mechanisms, the feed-forward mechanisms, kind of inbuilt into the system to keep kind of amplifying the signals up and up. And again, the main sort of theme here is that you're changing the way that this cell is responding to the outside world. You can change sort of how much stimulus it needs to respond. You can lower the threshold, or you're going to sort of dramatically increase the output of the cell. So again, the thumbtack hasn't changed. It's the same stimulus, but this cell now in this condition is going to respond in a much greater or in a different manner than this cell in the normal state. And you can sort of see now all the kind of mechanisms that are in place that lead to that. And again, here, just to sort of show you some sort of real-world kind of demonstrations of these things in action. This is what sort of demonstrations what we call activity-dependent plasticity. Just to show you how a spinal cord can sort of dynamically change its responses. So here, the most classic sort of example is the phenomenon called wind-up that you can see in spinal cord neurons. And we can sort of almost see the principles of what we saw in that last graph kind of happening right here in front of us. So if you kind of impale a neuron in the spinal cord in the dorsal horn, and you start listening to its activity as you present stimulus to it, and if you present the stimulus at a sufficient intensity, so you're going to activate the nociceptors, and you kind of give it a very sort of consistent train at maybe 0.5 to 1 hertz. What you'll see is that cell will have its initial response, so now we've got maybe the AMPA channels here responded, and then with the second impulse, because it's kind of riding the wave, it hasn't completely come back down, the membrane is sort of depolarized enough that that second impulse arrives, and the NMDA receptors are now recruited. So now the output of this cell, so the exact same sort of intensity stimulus is changed, and then we've got greater and greater responses. And then if you could probably do this for 20 or 15 and just see continual sort of ramping up of the cell output. And again, the input hasn't really changed. It's the sort of next sort of stage of processing, which has really been sort of amplified up and responding. And this example down here is probably more sort of to the point of kind of a clinical phenomenon, if you will. What you have here is a real sort of example of central sensitization in its purest form, in a sense. So if we took that same cell from up here, this dorsal horn neuron, and we sort of were listening to it, and we actually gave it a non-noxious stimulus, so just a light brush on the skin or something, the cell would actually really not be very responsive because it's not all that interested. This cell really only wants to know about noxious, potentially tissue-damaging stimuli. So light brush of the skin, and it's completely silent. So then we sort of say, okay, we take the nerve and we give it a conditioning train. We present 100 sort of really intense, a barrage of inputs onto the nerve that are going to act upon that cell. And now we sort of present that same light brush of the skin, this low threshold A-beta stimulation. And you can see that cell, which before would ignore this input, has changed in such a way. The threshold has dropped, some sort of mechanism has come into play, that now these inputs, which were normally ineffective, can actually begin to activate this cell. So if this cell is kind of hooked up to the brain to tell it about the outside world and something that's potentially tissue damaging, this cell is now going to start conveying information to the brain that light touch on the skin is actually quite painful and quite noxious. So this is quite a nice sort of demonstration of sensitization and some of the mechanisms of this allodynia. And so I'll just put this one up, and you can sort of, I think in the handouts online, it's very busy and there's a lot of stuff on it. And it's really just to sort of guide you, to serve as a guide of really the different kind of levels of pathways that can be involved in central sensitization. And that it's a very complex molecular phenomenon. And we didn't really even begin to cover most of these things. And you don't need to sort of go through and memorize anything here. The kind of the point of the slide here is that you basically looked at changes that can occur at the effector level, if you will, that can lead to these changes in processing. So changes in the threshold or the activation kinetics of receptors. And then also the important thing here is sort of the cellular processes that this leads to. So basically the excitability of the membranes or modification of the ion channel. This is kind of the underlying causes of central sensitization. And I think, and the other thing that we didn't really discuss, but I just wanted to bring it up here, is basically what we've been talking about of ways that pain can be amplified. And we've been talking about sort of increases in excitation. But it's always good to sort of remember that things can be amplified and you can have increases in excitability. And I think we saw this just the last talk in epilepsy, by not only increasing excitation, but by removing inhibition. And that's also a big problem in sort of pain processes, is reductions in a lot of these inhibitory neurotransmitters like GABA and glycine. And so these are other ways to get basically to the same sort of net sort of response, leading to this idea of disinhibition and sensitization. So this again, just use this as a guide. This is really sort of more of a study guide, just to kind of give you some of the general concept. It's not something I need that you know about the trafficking and happening. That's not. So we'll move over now into sort of the more, this is, you can sort of consider all of that the sort of nociceptive or kind of good pain. Everything is kind of in place to protect the nervous system, to protect the organism. And now we'll switch over and start looking at sort of when things go bad and we kind of get into this pathological thinking base. Is everybody okay with all the fundamental? So, as I said, basically what we have here is we have this sensitization process occurring in the dorsal ganglion in the spinal cord. And basically this kind of establishes sensitization. So we now have a hyperexcitable nervous system. But again, we sort of said this theoretically could all be sort of useful and good. But in chronic pain states, these sort of factors lay down the increase in excitability, and then for some reason, the system never kind of returns back to the baseline condition. So we have things that establish it, but we don't really understand yet why this sort of chronicity and why these long-term changes occur. And activity alone can't really explain sort of why a nerve injury, the pain from a nerve injury lasts for months and years on end. So other things typically now must explain or underline it. So changes, really fundamental changes in the way cells or the different gene transcripts that they're expressing. There might even be sort of fundamental sort of structural reorganization. So again, axon, you might have sprouting that is now innervating different cells in the vocal horn. These are all sort of possibilities, and it's still a very open-ended question in the research side of things. But one really interesting sort of avenue that's really kind of taken hold in the past 5 to 10 years, and it's probably really where all the new sort of therapeutic drugs are kind of being directed towards, because it seems to be where the most hope is for either targeting chronic pain, is in actually looking at activity of the non-neuronal cells in the nervous system, the glial cells. These now are kind of seen as actually, they were before typically ignored and were just kind of never really seemed to play any part in signaling or pain process. But this is actually where the focus has really come to play. And we actually haven't really seen much about the glial cells, and I think you can sort of see already, we're into our template. And we've had very little discussion of this really important class of cells in our nervous system, the glial cells. The two most fundamental ones, there's several others, but the two major ones that we'll be focusing on here are known as astrocytes and microglia. And these cells, outnumber neurons in the nervous system by a large factor. And generally they get very short shrift, or they used to get very short shrift in the neuroscience community. Glia actually means glue, and so basically that's how these cells were kind of seen. They were basically these structural elements that just kind of kept neurons from floating off into the ether, and that was really their job. But the role of glial cells, astrocytes and microglia in the nervous system, is actually to really kind of keep things in order. They're there, in a sense, to mediate and control homeostasis. So what they're doing really is they're always listening in to what the neurons are doing. And they're there kind of to see if anything goes wrong. So any sort of wild swing in activation or any invasion or any tissue damage, this is when these cells actually really kind of change and kick into this other sort of state and go into action and perform their job to sort of rectify the situation, if you will. So we can sort of say that these cells are highly reactive to these disturbances in the nervous system, and they switch over into this reactive state. And it's in this reactive state that they detected something's gone wrong. So we've had this wild swing of 10 times the amount of sensory input is impinged onto the dorsal arm. These cells detect that, and then now they sort of go into this reactive state, and now they can actually begin feeding back and talking to these neurons to sort of change the way the neurons actually are going to process information. So glial cells actually are in the nervous system actually kind of considered sort of resident immune cells. I mean, one thing they're there for, as I said, is to detect sort of foreign bodies like viruses and bacteria. They sort of serve many roles that our immune system does, but just within the monoclonal range. But as I said, they're also kind of very sensitive to sort of changes in the balance of activation and activity. So very large amounts of glutamate, excitatory amino acids, and some other sort of substances here that get released by nociceptors. These things can actually kick off and send the astrocytes into a reactive state. And so it's once they kind of go into this activated state is when they start producing the things that are kind of generally used to sort of fix things in the nervous system, to clear away foreign bodies or to kill off and engulf debris, let's say, if there's been some tissue damage. They start to produce things like pro-inflammatory cytokines like interleukin-1, tumor necrosis factor, this other one that is interleukin-6. And maybe more importantly is that they actually begin to produce excitatory amino acids like glutamate. So here you have a second source of glutamate that can be re-released and then act back upon the cells in the vicinity. And so now you can imagine, let's sort of take a scenario where there's been some significant nerve damage, and we've seen that we've had a significant increase in the amount of glutamate that was being released with every stimulus. This activated glial cell goes into its reactive state and actually begins to pump back out more glutamate. And so now we have this kind of vicious sort of cycle just feeding back upon the neurons that's really never allowing the cell to sort of dampen back down the normal sort of condition. And here's just examples. You can sort of see what I'm talking about when you sort of talk about a reactive microglia cell. On this side of the spinal cord, this is a side that had just suffered a nerve injury, and then this side is the sort of undamaged control side. And you can see the change in the morphology of these astrocytes. And then over here on this side, this is the same sort of thing going on. This is the nerve side and the normal non-injured side. And so these now cells are considered to be reactive. Here we would now have cells that are producing lots of glutamate, lots of these pro-inflammatory cytokines that are then, as I said, feeding back upon the cells in the nervous system and performing sort of the same sort of changes that we saw in the central sensitization example. And then this actually will continue on to persist for many, many months. People have looked at changes in astrocytes and microglia 3 to 6 months following nerve injury. And again, the nerve is probably regenerated and healed fine, but the astrocytes and microglia in the spinal cord are still sort of sitting in this reactive state. And so this seems to be a key sort of point that might sort of explain why pain is kind of going on and persisting much longer than it's taken for the actual injury to heal. And really, in terms of sort of drug development, targeting these cells has really become sort of a major, focus. And so a lot of people have now shown, very good experimental data that if you can prevent this change in reactivity of glial cells, you can significantly affect pain behavior, at least in preclinical rodent models. And now some drugs are actually starting to come onto the market to be tested, at least in clinical trials, in humans. But at the moment, or at least the first sort of drugs that have been shown are typically very kind of broad strokes metabolic inhibitors that are not very selective, and they just basically shut down the metabolism of both microglia and astrocytes. And this, I don't know how well the slide is coming up, but basically this is just an example from one typical drug known as penicillin, and there's several other drugs that have been tried, at least in preclinical models. And the point of these sort of here is that this is with the nerve injury, the cells went into this reactive sort of state, began to produce cytokines and glutamate, if you put the animals on one of these metabolic inhibitors and prevented that, basically over here, what they were showing is that their pain behavior substantially changed. So we don't really need to know all the specifics of this graph, but if you sort of are looking here, this line sort of indicates hypersensitive responses. So if you have sort of responses up here, that means you're in sort of higher amounts of pain. And we look at these guys down here, they started getting one of these metabolic inhibitors of the glial cells, and you can see their responses coming back down to more the normal baseline levels of the non-injured monkey rat. So there's a lot of encouragement, at least from preclinical data, that by targeting these glial cells and targeting these reactive processes, that we might actually have some good sort of treatments down the line that can prevent these chronic pain tics from developing. Okay, so let's move into the spinal cord now, and go from the spinal cord and start looking at more things up into the brain. So we've seen how everything kind of changes and can be processed in the spinal cord. Basically, once inputs come into the superficial dorsal horn or here, things immediately sort of make that first connection and that first synapse. And then it's these transmission cells, we can go back to using the kind of gate sort of model. These transmission cells will then cross very rapidly over into the other side of the spinal cord and then send fibers up in towards the brain. And there's two sort of major tracks that the pain signals are conveyed in. You have the spinal reticular tract and the spinal thalamic tract, kind of coming up here and here. And the spinal reticular tract is really kind of hitting cells in the reticular formation, which is kind of our arousal center. So this is important, basically, to alert us to the damage. And then the spinal thalamic tract is basically the first stop that these cells are going to make is within the thalamus before they're going to go on up into the synaptic cortex. And of course, too, on this diagram, we also have some descending inputs. We won't really focus a lot on those because the wiring is actually quite complicated. But it's worth noting that the brain does obviously send signals back down into the dorsal horn. Again, in terms of, you can consider this gate control theory in this model, they can sort of modify and open or close the gate as well, coming from regions, particularly main ones, the periapical brain. We won't focus too much on the descending inputs today. So, the point, actually, a major point of this slide is that in the sort of specificity theory, or in the sort of standard classical view, this is kind of basically really all you used to need to know about pain. Once you got to the somatosensory cortex, this is where pain was interpreted, and that was basically the end of the story. But we've sort of seen that initial definition by IASP, and we sort of now kind of talked about the gate control theory of pain, and we sort of know that pain is not just really a stimulus and a response. And there's probably a lot more going on than just the somatosensory cortex when it comes to pain. And so now, actually, what people tend to talk about are pain as having sort of three major dimensions. So we have the sort of standard specificity theory stuff about sensory discriminator. So we know, basically, the nervous system can tell us, the location, where pain is coming from, the intensity, and how long it goes on. That sort of initial wiring that we just saw, the spinal thalamic tract and the cortex, they're all very useful at describing those aspects. But we know that pain, as I said, is a much more complex experience than that, and there's also these affective motivational components to it. So things like pain often has a quality to it. It can be very unpleasant and make us sort of feel very awful or very sick. And so that also kind of comes into play. And then finally, pain can be influenced or affected by very high-level cognitive evaluative processes as well. So things like attention, anticipation, and memory, or our previous experiences in certain contexts, can all influence basically the pain experience that we're going to sort of have in that situation. And the thing to remember, too, is that all of these sort of systems are kind of working either in parallel or potentially even influencing and acting upon one another. And that three dimensions of pain really sort of stemmed out of a lot of the early imaging research that was done back in the early 90s. So when people started to get really sort of fancy high-end fMRIs and PET scanners, and started putting people in the machines and sort of presenting them with enough stimuli, we realized very quickly that it was not just the somatosensory cortex and the thalamus that lit up. In fact, if you look and you put a patient into an fMRI and you present a noxious stimulus, you get the thalamus lighting up and you get the somatosensory cortex lighting up. But consistently in almost every trial and in every person, you get other sort of regions that always sort of activate. Regions involved in attention, memory, and typically emotion. So areas like the anterior cingulate cortex, the ACC, is very common. And another region that's caught a lot of people's interest is the anterior insula. And so the insula is kind of linked in with the limbic system, so the amygdala and the hippocampus, which often is very important for emotional sort of processing as well. And actually, there's a very interesting sort of clinical phenomena that, just as an aside, a disorder called pain asympholia is often has been described, and it's very rare, and it can occur in only a handful of people. But what can happen is if you have a very selective lesion in this insular cortex, what you get is sort of a person who basically can detect pain and recognize that it's, something is painful, but their sort of emotional output to the pain is typically it's off, basically. So as opposed to sort of grimacing or screaming or feeling very flat, or they might even start laughing as if you were tickling them. But then they'll say, oh yeah, that really hurts. It makes sense. And so these are the kinds of things that can happen or that sort of demonstrate that pain kind of goes beyond the simple sensory system. And again, too, now if we want to start looking at sort of the plasticity and how dynamic pain is, we've moved up to the brain now, we see the exact same phenomenon happening as we saw in the dorsal ganglion, as we see in the spinal cord. Here's just one experiment of some imaging done. Basically, in every row up here, we have some functional imaging where a patient is responding to exactly the same noxious stimulus, but the context of the situation is changed. So in the first row, he's being told to basically pay attention to something pinching onto his hand, causing some sort of painful stimulus. And we can see the pattern of activity here. In this condition, he's being told to look straight ahead and not really do anything. And in this condition, it's called the diversive category, so he's probably got to do some complicated math problem. And you can see now, we've got exactly the same amount of force, the same noxious stimulus hitting this brain, but look at the difference in activation patterns going on here. And so the response, or the perception of pain, or that experience, you can sort of just see from these images, are quite sort of modifiable and very context dependent. And I'm going to point out on this slide too that we have the differences between the intensity coding and attentional networks engaged differently. So again, the context of the situation, whether you're being told to do a difficult calculus problem, your brain's response and your perception of pain is going to be very different to whether you're actually focusing very exclusively on getting a needle to a jab into your arm. And here's some kind of interesting sort of experimental data that I think kind of illustrates some of the fundamental ways in which our brains are wired to sort of for pain, if you will. And basically what you have here is kind of some experiments that have really just come out in the last few years that have shown that our brains basically respond to pain even if we aren't really experiencing the sensations ourselves. So it's this notion of pain empathy, that within our brains, we're actually kind of wired up to respond to pain happening outside of us, if you will. So you can sort of imagine here, just viewing somebody else in pain, just viewing a situation of a hand getting trapped in the door. I'm surprised there wasn't a phone catch. But anyway, just kind of viewing these situations, what you get is sort of activation patterns as if the same regions activate as if you were experiencing this pain, minus the thalamus and minus the somatosensory cortex. But basically this idea of a pain matrix has kind of come into play, where things like the anterior cingulate cortex and the insula are all sort of activated even just by watching somebody else in pain. And really an interesting sort of experiment that kind of showed the importance of this kind of phenomena was done a little while ago. Basically what they did was they dealt with a clinical scenario known as congenital insensitivity of pain. So here you have people who basically don't experience pain like you and I. They basically have never really felt pain ever. Now these are not sort of superheroes that really that we all want us to strive to become. These protein sort of people generally don't live very long. Not being able to detect pain is generally not a very good thing for you. They tend to sort of, again, have broken bones constantly. They develop lots of ulcers and sores because they don't sort of shift their weight when they're standing, etc. So it develops basically through sort of problems in the way the nervous system develops. So the nociceptors, those small dark C fibers, in a lot of cases just don't develop properly. There's specific mutations in certain receptors, and it's not important to know. But one sort of class of these congenital insensitivity to pain is this HSAN4, and that's what these patients have. So basically, by a mutation in this gene, and basically all those small dark C nociceptors just don't develop. So they've got dorsal ganglion in which they have A alpha cells and maybe an A delta cell, but no little C nociceptors, and probably not actually any A delta cells either. And there's some other sort of scenarios too in which people can develop these or be born with these congenital insensitivity to pain. But they're listed here, some differences in channelopathies that are very similar to what we saw in epilepsy talk, looking at a very specific sodium channel. And here the channelopathy is that this sodium channel just isn't there. So they don't have this sort of important generator ion channel to generate impulses from the periphery. So anyways, these are the causes for these people. But the interesting question was, if you kind of go back to that pain empathy scenario, here we have a group of people who really don't sense painful stimuli. What happens if we sort of put them into that scenario where they're watching somebody else in a painful scenario? And the answer is that their brains respond just like you and I. You get the exact same sort of patterns of activation in the brain of this sort of pain matrix, if you will, of all those sort of attentional networks and the cognitive functions. These things all sort of still come into play, even though they don't have the sort of somatosensory, that descriptive aspects to it. So this really, I can tell us, or kind of shows us, if you will, kind of the fundamental nature that pain has for us as organisms. That not only do we need to detect pain and be able to sense it on ourselves, but it's actually must be very useful evolutionarily too for us to communicate and recognize pain, to sort of call us into action and to communicate these things. And so this little diagram just kind of illustrates that idea that we have these three dimensions of pain. As I said, they're kind of running in parallel where we have sensory, emotional, cognitive aspects coming in. And then even though you can sort of take away all the sort of sensory aspects to it, these other sort of components, the emotional and cognitive, are still very critical and are still inbuilt into the system. Sort of, again, demonstrating how important sort of pain can be, not only from a survival point for our own sort of bodies, but also in terms of a social context of communicating with those around us as well. Okay, so we have a few minutes left, and I think we'll sort of move over into kind of the treatment side of things. So we've kind of seen the kind of fundamentals and the mechanisms that have led to sort of the changes that trigger some of these chronic pains or these abnormal pains. So what are some of the sort of fundamental principles going about actually dealing with pain? So we'll go back and start again out in the periphery, and we'll kind of take our primary aspect, this is the terminal of the skin. And it's being acted upon by all the different sort of mediators from the inflammatory suit. And we'll focus over here on prostaglandins. Probably the most common, as I said, treatment that we have, we probably do that. I don't even know what the numbers are in terms of productivity, but prostaglandins are really sort of the major first sort of target that we go after. So non-steroidal anti-inflammatories, so our aspirin, Tylenol, ibuprofen, what am I missing? So, I mean, this is really what these drugs are doing. They're targeting that one sort of element of the inflammatory suit, production of the prostaglandin. And we've already seen what the prostaglandins are doing. We know that prostaglandins are activating receptors, leading second messenger, the channel. So by basically going upstream to preventing the production of these prostaglandins, that's sort of the one sort of mechanism of sort of dampening down and controlling the excitability and activity of that cell. Now, there are other ways you could go about sort of targeting pain out in the periphery. Of course, not only would you want maybe necessarily to prevent that increase in sensitization to the prostaglandins, but you can go the opposite way and increase inhibition too. So, cannabinoids or opiates like our morphines and fentanyl, for instance, these all have sort of selective receptors on these nociceptors. And what they're going to do is now, so again, work intracellularly, but instead of promoting and increasing the excitability, they're going to activate inhibitory second messengers that are going to shut down the production of adenoid cyclase and these protein kinases. So by inhibiting and cutting back on the sort of the protein kinases, we're going to sort of limit the sort of changes that are going to occur at those silicon channels. And so we're going to prevent sensitization in that way. Now, in really sort of strong, sort of severe instances, and we really need to basically just shut everything down, say we're going to go to the dentist and we're going to have to people, we really don't really want to just sort of dampen down some of the sensitization. We need to really quiet the whole activity in fiber. And that's basically what our local anesthetics like lidocaine are doing. They're sort of coming and blocking all those sort of fundamental channels which are important for generating the impulse. Now, as a day-to-day pain reliever, you and I, if we have a toothache or if we have a headache, the last thing we really want to do is probably go into this complete anesthesia and numbness. So these are not really sort of useful in sort of non-pathological, non-clinical conditions. But again, I don't think many of us would want to sort of have teeth or wisdom teeth taken out if we didn't actually have a lot of stuff on board. Now we can move into the spinal cord and sort of see similar kind of principles at play. Now we've got our central sensitization scenarios kind of playing out. We've seen the NMDA receptors being activated, and we've got tremendous amounts of glutamate spilling out because the activity increased out in the periphery. And this is really where some of the more hardcore sort of treatments like the opioids and morphine given kind of right into the spinal cord and into the base, that what they're going to be doing is targeting this kind of process. So opioids can act presynaptically, right? I'm losing my pointer here. The opioids can act presynaptically, and what they'll do is inhibit basically that surge and release in glutamate. Opioids can also act postsynaptically on those second-order transmission neurons as well. And basically the net effect is really just to dampen down sort of the activity and excitability. And these are very potent, very powerful sort of analgesics and painkillers. And the other sort of target, or the other sort of class of drugs beyond opioids, is you can get even more fundamental again and go after sort of the generator ion channels that are important for the action potentials themselves. And that is drugs that will actually target calcium channels. Now those again can be a little precarious too, because we have calcium channels all throughout the body, and they're very fundamental for neurotransmission. So you want to be very careful if you're going to sort of shut down the transmission through a calcium channel, because you don't want sort of these nasty side effects of paralysis or ongoing sort of numbness. Now one of the problems though with these pathological pain states and neuropathic pain in particular is we can sort of see we have this sort of nice route that we can basically dampen down and quiet pain down. So, opioids seem to be the most logical sort of approach. But it turns out that in conditions of neuropathic pain, so when the nervous system, the peripheral nerve gets damaged or the spinal cord gets damaged, and we've switched over into that sort of chronic maladaptive pain state, for some reason opioids don't work very well. They either just completely ineffective or they wear off very quickly and become sort of ineffective in a very sort of short period of time. And things like tolerance to the opioids actually goes very quickly. So now it's required, you constantly have to increase the dose of the opioid to get the same sort of pain relief happening. And this has really been a big area of research too, trying to understand why do opioids not work in this setting. And it's interesting actually, because if you sort of come back to our friends the glial cells, they might actually hold anti-glial drugs. So it turns out that if you go back to our microglia and astrocytes, that microglia and astrocytes are actually very responsive responsive and will take over into that reactive state in the presence of opioids, and particularly chronic opioids. So a nervous system that's sort of given opioids for prolonged periods of time, so here's morphine over like a 7-year period, these astrocytes and microglia sort of switch over into that reactive state. They sense this as something sort of abnormal in the system. And we already know what happens when we have these astrocytes and microglia tick over into that reactive state. We have a system now that basically is almost mirroring the conditions that are associated with nerve injury or pathology. And so actually, what we might even have is a mechanism or the reason why these opioids are failing to be effective. So the opioids may sort of be useful at dampening down the transmission, but the knock-on effect is that they're setting up the conditions for this hyperreactive spinal cord, and it's just going to continually feed back on itself. And so this is still quite a theoretical sort of idea. There's a lot of work kind of being done in this area. And I think some of the more, the next generation of drugs to treat sort of chronic neuropathic pain, again, are going to be targeting these glial cells with not only the idea of preventing pain from developing, but maybe as adjuncts to target them and see if we can make opioids, which we already know are pretty effective at relieving them, make them work just that much better. Now it's interesting actually, so in terms of neuropathic pain, pathological chronic pain states, where the opioids don't work, really the first line of treatment for most of the doctors is actually to go with long-standing antidepressants. Now there's two probably good reasons for antidepressants being so effective in these chronic pain states. We've already seen that pain has sort of cognitive and emotional sort of components to it, so the main job of these drugs is obviously to make people's moods improve. So if you can sort of improve sort of that aspect of it, you can sort of obviously see how you're going to modify or change perceptions and feelings about pain. But antidepressants in and of themselves, we know the main sort of job that they do is that they elevate a lot of neurotransmitters which are actually quite effective at inhibiting activity in the spinal cord. So serotonin and norepinephrine are really the major kind of targets of most antidepressant drugs. And you can see from this kind of little experimental diagram and how sort of potent serotonin can be in the right context of actually dampening down the excitability and activity. Now it turns out though, in terms of the antidepressants, it's not just serotonin alone that's really sort of necessary. A lot of the antidepressants that only affect levels of serotonin are actually not that good in terms of treating neuropathic pain. It seems like you sort of need a little bit of a cocktail, the antidepressants that actually work on both the serotonin and norepinephrine system. So these are the classic drugs known as the serotonin and norepinephrine reuptake inhibitors. And so basically the idea that these drugs, how they work, right, is that both serotonin and norepinephrine, the neurotransmitters, they get released into the synaptic cleft, will bind the postsynaptic receptor, and then basically cause their action. Any sort of transmitter that got released and didn't bind to the receptor gets taken up very quickly by the cell that released it. There are active transport mechanisms. These drugs basically block that active transport and let serotonin and norepinephrine linger around in the synapse. So you just have this building up of the levels of these two neurotransmitters, which then can have their sort of inhibitory component or their antidepressant component. And the main sort of one that's kind of on the market now that's only recently, has recently been approved to treat neuropathic pain and also a very severe, very common sort of chronic pain condition called fibromyalgia, is this drug, duloxetine, which is sort of just an example of one of these classes of drugs. So this is really, I think, what's kind of in the armament of the clinicians who deal with patients in chronic pain. So I'll finish up there. I'm just going to put up this little slide. And this is kind of just a table that, this is sort of, you know, as I said, the clinicians would kind of use this as their strategy when they're dealing with patients who have these sort of abnormal chronic pain states. And this is sort of your sort of strategy, your first, second, and third line approach. And so basically, chronic neuropathic pain, you're often going to deal with antidepressants, so these are tricyclic antidepressants, and then probably mixed with what I'm going to classify here as calcium channel blockers, drugs like gabapentin and pregabalin. For all intents and purposes, these drugs are not calcium channel blockers per se. Gabapentin and pregabalin actually just affect the dynamics of calcium channels. But the point is that they're sort of going to affect excitability in that way. And then typically we'll move up into the other sort of category, the serotonin or norepinephrine. And if things are quite bad, then sort of move into these local anesthetics and helpful life. And then finally down at sort of a really severe sort of case you get into the fourth, third line, where really sort of strong high-dose opioids are really required. I think most patients tend to sort of remain in kind of these levels, going up and down, titrating them for many, many years. And unfortunately, this is basically what I work with, and a lot of patients find things are still actually not that bad. So a lot more research still has to be done. So again, I'll apologize that you didn't have a note. I like to bring it down, but I think this should be up online. I think you can sort of see the diagram more clearly. Now, if you haven't, there's a summary I can provide. So enjoy reading these, study hard.